Okay, so we're going to continue our discussion of neurological issues with some acute, specific neurological problems. So, tumors. The biggest problem with brain tumors, whether they're benign or malignant, is the fact that they take up space. That as a tumor grows, even if it's a benign tumor, it's going to increase intracranial pressure because the brain takes up the whole space of the skull, the whole cranium, and there's no room for anything else. And so these lesions will increase the pressure in there and threaten the function of the central nervous system. If they are benign, they're accessible, they can be removable and will not be as life-threatening. If they're malignant, they're much harder to remove because they don't have well-circumscribed borders. Accessibility is a big problem too. A benign tumor that's deep in the brain, to dig it out will cause too much damage. So it's an important problem. Now, most of the tumors, primary tumors, not metastasis to brain, most of the tumors start in the glial cells. So they start in the astrocytes or the microglia or whatever, the epidermal cells, rather than the neurons themselves. And we classify the tumors, they're all gliomas, but we classify them by where we find the tumor and what the cell derivation is, like where the tumor comes from. Some of the tumors will start in the meninges. Some of them start in the pituitary gland, which is glandular epithelium. But they will take up space and cause very similar neurological effects. And the neurological effects are not necessarily focal to where in the brain the lesion is, but can be much more global because of that increased intracranial pressure. Because the blood-brain barrier and the fact that the cerebral spinal fluid stays within the central nervous system, a primary malignant tumor really can't seed outside of the central nervous system, because if the cells break away and colonize someplace else in the cerebral spinal fluid, it's going to be within the central nervous system, and the blood-brain barrier prevents seeding to hematological route, so it stays there. The brain is suspect, or is subject to metastasis, especially from breast or lung. And again, that tumor may be in the meninges or could be anywhere as a metastasized secondary tumor. But the effects are similar to the primary tumors because most of the effects are of this increased pressure. So, like all malignant tumors, the malignant brain tumors have no well-defined margins. They're invasive, they project into adjacent tissue, and are difficult to remove. And oftentimes, we get inflammation around that tumor because it's malignant, and that can be very destructive to neural tissue. Cerebral hemispheres in adults and cerebellar or brainstem in children are more common. And don't particularly know why. It's probably got more to do with growth than it has to do with function. Just a photograph of a brain tumor in the cerebral hemisphere. Obviously, the person that this photograph was taken of didn't quite make it. So, the site of the tumor determines any focal signs. So, if the tumor is near one of the speech areas, you're going to have that. If it's in the occipital lobe, you're going to have visual symptoms, etc., etc. There will often be seizures that will look epileptic. And oftentimes this is the first thing that people seek treatment for, because seizures scare the shit out of you. Headaches happen because of the increased pressure, but it's not necessarily what people seek help for first, because it's a headache, and it has to go on for some time before people actually look into it. As that pressure increases and the brainstem starts to be pressed, then we're going to get vomiting and that kind of thing, maybe some breathing issues, that kind of thing. If the pressure is pushing the frontal lobe, you're going to get lethargy, irritability, behavioral changes, personality changes. And if it starts to affect the cranial nerves, you're going to have the pressure will affect the cranial nerves, and you're going to have some cranial nerve problems. And oftentimes, just because of the architecture of it, it's the facial nerve that is affected. So you get unilateral facial paralysis. The optic nerve can happen, or the ocular motor nerve can happen as well, although there's a little more space in the foramen that those nerves go out. So you can have visual disturbances. Often the visual problems are actually because of the pressure on the occipital lobe rather than on the cranial nerve. We don't tend to get auditory problems because that's all encased in the petrous region of the temporal bone and not as prone to pressure. We don't normally get systemic signs of malignancy, so you don't get that same wasting and malaise and all of the signs that we get from malignant tumors everywhere else. And that's because of the blood-brain barrier. A lot of these tumors are radio-resistant, so radiation doesn't work very well. And chemotherapy, because of the blood-brain barrier, isn't the ideal thing. Surgery is the preferable thing if the tumor is accessible. And that's the biggest issue right there. Okay, another acute disorder would be the vascular disorders. So ischemia locally, so local damage because of blockages in the cerebral arteries. So the anterior cerebral on the right side would give that frontal lobe some damage. The middle cerebral would give the parietal lobe. The posterior cerebral would give the occipital lobe and the cerebellum problems on that one side. So clots or blockages within those local arteries will give a problem with that area that's supplied by that artery. And that's ischemic problems. So there's not enough ATP for that part of the brain to be working properly. Hemorrhagic lesions, so if there's a hemorrhage, the problem with that, you end up with a hematoma, and the blood clot takes up space, just like the tumor does. And you get this increased ICP, and that causes the local ischemia, but it causes the generalized symptoms the same as the tumors. Now, there is global cerebral ischemia can happen. So this can happen because of heart failure, for instance, and cardiac output drops significantly or totally. And we end up with brain death, complete loss of function of the entire brain. The brain, every action potential in every neuron requires sodium-potassium pumps and ATP to reset it. The brain is very sensitive to a loss of ATP, and the ATP requires huge amounts of oxygen. And so if there is an ischemia to the brain, there's damage very quickly. Now, you'll see that it says generalized cerebral edema. One of the problems that's going to happen here, and I'll explain this, and it happens in the heart, it happens in a bunch of places. When you have ischemia, a neuron will have a sodium on the outside in the interstitial space and less sodium inside the cell. And an action potential, the nerve firing, is opening sodium gates and allowing sodium to go into the cell, depolarizing it and having the action potential, as you learned in physiology. Then the sodium coming in pushes potassium out, repolarizes the cell, because the potassium leaves the cell because it's positive and it's trying to get away from the positive sodium. And then we use the sodium-potassium pump to bring potassium back into the cell and put sodium out. And we bring 2 potassiums in, 3 sodiums out, and we get back to the resting membrane potential so that we can have another action potential. If we don't have the ATP to reverse the potassium and the sodium levels, then the problem is we have way too much sodium inside the cell. And because it's 3 sodiums to 2 potassiums, the problem becomes then the osmosis, because the sodium will create an osmotic gradient. And liquid will flow into the cell to try and equalize will flow in because of osmosis. And that liquid going in causes this edema. And the cells, the neurons, will expand and perhaps burst. And if they burst, then the cell is dead and you can't regenerate it. You can't get it back. So this is generally a very dangerous thing. So we first lose the function because we can't have the action potentials. Then we end up with this osmosis causing this edema and cellular death. So transient ischemic attacks are ischemic attacks that don't last for very long. It's a temporary localized reduction of blood flow to that part of the brain. So it can be caused by vascular spasm. So if there's a vascular injury, as you know from studying hemostasis, the first reaction is spasm. A small embolus can end up and obstruct the flow. But if it has to be a small embolus for a TIA, because then the fibrinolysis will happen and it will be taken away, and blood flow will occur. Partial occlusions of the artery can make it difficult, and so blood pressure changes can give you this transient ischemic attack. Atherosclerosis, which is the kind of thickening of the arterial walls, will also do it too. Local loss of autoregulation, this is vasoconstriction, vasodilation, allergies, things like that can cause these TIAs. It's very difficult to say that somebody had a TIA, except from history. There are no tests that can show it. We diagnose it because of the history of what they say had happened, but now has gone away. So it could be intermittent, and it depends on the location of the ischemia. So if the ischemia is in the middle cerebral artery and it's the primary motor cortex that's affected, we're going to lose motor function. If it's in the occipital lobe, and then it's going to be visual disturbances. I think in my clinical experience, it's been mostly what I've seen has been visual disturbances, and most of the occlusions have occurred in the vertebral arteries rather than the carotid, internal carotid arteries. Some numbness and paresthesia, maybe some aphasia, confusion. The biggest thing about transient ischemic attacks is people get better from them, but are they the warning sign of more permanent or more serious obstructions related to atherosclerosis? And it should be investigated, because TIAs can become cerebral vascular accidents, strokes, quite easily. So, especially if it's repeated attacks and the attacks are similar. So, and I think the other thing about the TIA to remember is that there is still enough oxygen being made that some ATP is being made. So it is a diminishing of function, not a complete loss of function. The cerebral vascular accident, a stroke, is a complete infarction. The blood supply is occluded and or ruptured, and blood is not getting to that part of the brain, and the cells die. This could happen because an aneurysm has ruptured and there's a bleed, or it can happen because there's an occlusion of one of the cerebral blood vessels. So a fairly large occlusion, usually. The big problem is that there is not a lot of storage of oxygen, and within 5 minutes of ischemia, we're starting to get irreversible damage. Where the damage happens, where we have complete infarction, the cells swell to the point that, because of the osmosis, that the cells burst and we end up with necrosis. And as you know, necrosis leads to inflammation, as opposed to the apoptosis, which doesn't. The area that's necrotic, all function is lost. There's nothing going on there. At the time of the stroke, the area around that's inflamed loses function as well. But that function can come back once the inflammation is brought down, if the infarction doesn't continue. So this is the kind of the point of rehabilitation. Now, there's also a certain amount of plasticity in the brain that we are really making great strides towards understanding, where we can lose complete function of an area of the brain that has died and is necrotic. However, we can train other parts of the brain to take over those functions, at least partially. But it's a long, difficult process. So when you look at this, you can see these infarctions here in the brain. It's interesting, when I was taking anatomy for the first time, we had cadavers, and so I worked on the same cadaver 2 days a week, 3 hours each one of those days, so 6 hours a week. We cut on the same body from Labor Day until the 24th of May. And the body that I worked with, he had, I counted 15 strokes, areas of necrosis. Now, this particular view is, you can see the hematomas here. So this is hemorrhagic infarction. So this is a bleed into the area rather than an infarction. So we could have this occlusion by anatheroma, which is plaque buildup, the same as you get in the coronary arteries. This develops over time, probably lead to some TIAs, and as it grows and inflames, then it can lead to a complete stroke, a CVA. More commonly, an embolus. So a blood clot breaks off from usually a heart valve, usually on the mitral side, so on the left side, or the aortic semilunar valve. The clot becomes an embolus. It goes up and causes ischemia and infarction beyond the place where it lodges. Now, because the cerebral arteries are always getting smaller, eventually the embolus will hit an artery that's the same size and cause a complete obstruction. The larger the artery, the more area that ends up ischemic. Another type of stroke is intracerebral hemorrhage. So this can be caused by severe hypertension. It can be caused by an aneurysm that blows out because of hypertension, etc. Now, usually when this happens, the first part of the stroke is the one hemisphere, and so the symptoms are very typical of the stroke. But very quickly, because of the space taken up by the hematoma, it becomes effects in both hemispheres, plus complications by blood loss. And so, so the secondary effects of bleeding will complicate it. So just a table to look at it. So a thrombus, so a clot within the artery, is predisposed by atherosclerosis, gradual onset, transient ischemic attacks. It happens at rest. It doesn't increase the intracranial pressure. If this is gradually growing, then oftentimes collateral circulation has growing, there's been angiogenesis that new blood supplies are formed because of the ischemia. So the damage may be less permanent. An embolus is a sudden onset. It usually comes from the heart. It doesn't cause an increase in pressure, and it's local and like local effects because that part of the brain is damaged. Hemorrhage predisposing is hypertension. It's sudden, usually at straining at something, like lifting or things like that. It's high increase in pressure and widespread, severe, fatal type of things, signs and symptoms. A good friend of a friend of mine, so a guy that I kind of met 2 or 3 times, was really prone to road rage. And he had high blood pressure anyways. He was a big guy, really prone to road rage. And a guy cut him off, and so he chased the guy, and at the next lights got out of the car, was so mad, he went forward to the other car, punched the guy that was driving the other car that had cut him off, and apparently he was red in the face and just screaming with rage, and had a hemorrhagic stroke and died right there. It was on Ann Street quite a few years ago now, but it was like it happened that quick. So post-stroke, we can look at MRIs to determine the cause, to see where it is. Big risk factors are anything that's going to damage the walls of the blood vessels or cause atherosclerosis. So this is diabetes, hypertension, autoimmune things like lupus, sleep apnea, smoking, obesity, right? A big combination, a big risk factor are women who take oral contraceptives and smoke at the same time. And then, of course, there's congenital malformations of blood vessels. A patient of mine, she's only 35, her brother died of a hemorrhagic stroke just last year. Her parents are also patients of mine. It was fairly sudden, and it turned out that he had this aneurysm that blew out, and they knew about the aneurysm. So she got checked and found out she has the exact same aneurysm as a congenital malformation. So she's watching it very carefully and is making absolutely sure that she's maintaining her blood pressure and that kind of thing. So, what are the signs and symptoms? Depends on the location of the obstruction, the size of the artery involved. So if there's collateral circulation, you maybe not get as much. But always there's a lack of voluntary movement or sensation on the opposite side of the body. So we end up with a flaccid paralysis. So you can't move, but it's not tonus, like there's not like a flexion or anything. It's flaccid. We get the spastic paralysis later, but initially it's flaccid. There's no motor neurons going. You can look up the stroke scale. It's for rapid diagnosis. You're going to learn these things in your assessments courses and things like that, in your clinical courses. But time is of the essence. The biggest thing is time. The quicker that you can get treatment, the less severity of damage to the brain. It's important. Minutes count. So we give people clot-busting agents. But this only works if it's a thrombus or an embolus. If it's a hemorrhage, that actually makes it worse. Surgical intervention may be necessary, especially if it's a hemorrhage. You can cauterize it. Glucocorticoids are used, so this is like prednisone, and that's to minimize the inflammation in the surrounding tissue, like the surrounding brain tissue, to minimize the effects. Supportive treatment makes sense. Occupational physiotherapy, speech therapy, all are about rehabilitation. And try and prevent reoccurrences. And the quicker you start to rehabilitate, the more likely it is that you're going to get something working again. The longer you leave it, the worse it is. So, I've mentioned cerebral aneurysms a couple of times. Usually it's where there's a branching. We call these berry aneurysms. It's just a weakness in the wall of the artery. Chronic hypertension will make these aneurysms grow. Usually they're small and asymptomatic little bulges, and then they get bigger by blood pressure, by increased blood pressure. Sometimes these things leak a little bit, and there's a slow bleed, and so blood will start to accumulate, and you get a headache. But it's a pretty severe headache, and this is actually a good thing because you'll seek treatment and probably get treated. If it completely ruptures, you get a sudden, huge increase in intracranial pressure and usually die. So the common places are along the circle of Willis, and they look like little berries. And it's the points of bifurcation. It's the points where there's a branching. So depending on where, so if we look at this one here, that's right at the basilar artery, and these are the posterior cerebral arteries. This is doing the occipital lobe. So if it happens there and the mass is here, you're going to have visual symptoms primarily. If it's here in the middle cerebral, here or here, you're probably going to get more motor and sensation issues because that's where the motor cortex and the primary sensory cortex is, etc. Make sense? Headache and photophobia happens because of the pressure increases. Nuchal rigidity. So the nuchal ligament is in the neck, and so as the meninges swell, they pull on the nuchal ligaments, and the neck becomes really, really, really stiff. And it's because the meninges are irritated. We're going to see this nuchal rigidity when we talk about meningitis as well. Vomiting, seizures, loss of consciousness happen because of the pressure pushing the brainstem into the foramen magnum. If we know that these aneurysms exist, you want to surgically cauterize them and treat them if they're big, and keep blood pressure at bay. Okay, the next group we're going to talk about is different infections. Lots of causative organisms to it. Neisseria. And Neisseria is is similar to the bacteria that causes gonorrhea, but this causes meningitis. And it's meningococci. It's spread by respiratory droplets. So it spreads kind of like the common cold or flu or COVID. And there's a lot of asymptomatic carriers of it. Children are susceptible because of their immune systems. In neonates, so newborns, E. coli is common, and it's because of premature rupture of the amniotic membranes during delivery and mixing with the flora and fauna down there. Haemophilus influenzae will affect young children. Streptococcus happens in adults. Usually when there's an infection, a brain infection, central nervous system infection, there's a sudden onset, and it's severe headache, neck pain, back pain. So this nuchal rigidity that we talked about happens. Oftentimes the occipital lobe is hypersensitive, so you end up with photophobia. We can end up with this Koenig sign and Brzezinski's sign. Both of these signs are fairly similar. What they are is you try and do a straight leg raise for Koenig, and the hamstrings get really, really tight. And so the person can't flex the hip without bending the knee. Brzezinski's sign is you bring your chin to the chest and the legs raise at the same time. And both of these have to do with tightening the spinal cord and then the sciatic nerve. So the sciatic nerve is just long enough to go down the back of your leg and across your foot. And if your leg is extended, the sciatic nerve is fully extended. And when you bring the hip up, it pulls on the sciatic nerve. If you have inflammation anywhere in the central nervous system, it is going to pull the spinal cord tighter and make it impossible for that nerve to be long enough. It hurts a lot. And so by bending the knee, you take that pressure off. The same thing that when you flex the neck, it pulls the spinal cord, which then pulls on the sciatic nerve. And so the knees bend and raise in response to that. That just says that things are tighter than they should be. Vomiting, irritability, fever, chills, leukocytosis, those are all things that happen with any infection. This will progress to stupor, like passing out, or seizures, or both. This next slide is interesting. For some reason, every book that has ever mentioned this has this same painting. It's pronounced Opisthotonus. And what this is like an arched back and an arched neck. And it happens because of severe central nervous system issues. Yeah, you will probably never see it. I think kids are more susceptible, but yeah. So, how do we diagnose it? We examine the cerebral spinal fluid, your lumbar puncture, and look for the causative organism. You treat it with antibiotics, antimicrobials. You try and minimize the intracranial pressure and treat for seizures. You want to decrease the inflammation and therefore the edema that's going on, so you use prednisone, glucocorticoids. For some meningitis, there's vaccines. Other agents, there's not. So this is just looking at the neutrophils within this CSF because of bacterial meningitis. Okay, brain abscess is a local infection. It's like a pimple, right? Often it's in the frontal or the temporal lobes because sinuses and there's very little bone between the outside and these lobes of the brain. There's some necrosis of brain tissue with edema and inflammation around it, the same as a pimple. It usually spreads by the sinuses or in through the ears or maybe the throat up to the sphenoid sinus, that way. It can come from the lungs because of a septic embolus. So if you have bacterial endocarditis and it's seeding the bacteria from the endocardium into the bloodstream, it can end up in the brain. There could be sites of injury, so like a head injury, and like a fractured skull or something like that, or surgery will do it, and can cause these abscesses. And it's no different than a tooth abscess or like any other abscess. You drain it, you use antimicrobials to deal with it. The problem is that if there is necrosis, that area is not coming back. Here's just a picture of some. Encephalitis is an infection of really any part of the brain. And inside, cephal, head, itis, inflammation in the head. The parenchymal tissue is any functional tissue. So these would be the neurons and the glial cells. Or it can happen in the connective tissue, anywhere in the brain or the spinal cord. So it could even include the meninges. Necrosis, inflammation happen, and it's usually a viral infection. So you get headaches, stiff neck, vomiting, seizures, fever. You'll notice that the symptoms are all the same. We tend to call it encephalitis if it's viral. So this would be things like Western equine encephalitis. So it's an infection spread by mosquitoes. St. Louis, spread by insects. West Nile is spread by mosquitoes. Lyme disease, spread by ticks. So Lyme disease tends to be more systemic, but you will also get brain encephalitis can happen. Borrelia burgdorferi is the thing. It's a spirochete, so it's a lot like syphilis. So that's why they think there's secondary and tertiary stuff. Herpes simplex can cause necrosis and hemorrhage and things in the brain, so that's an encephalitis. Can cause this. Other infections we're not going to worry too much about, but rabies. So what happens is that the rabies gets brought up towards the central nervous system because of a bite on the periphery, and it's taking advantage of the retrograde transport of the peripheral nerves to get back to the CNS. And then you end up with heavy hyperirritability. Just think of a mad dog, right? Sensitivity to touch, seizures. Salivary glands, so difficulty swallowing, fear of fluids, but foaming at the mouth. Tetanus is caused by Clostridium. It's endemic in the soils. It has to get in through a wound. We call it lockjaw. So you get this jaw stiffness. You get these tonic muscle spasms because it interferes with the normal neuromuscular junctions. Headaches, respiratory failure. And it's caused by exotoxins. So it's one of the few things that it's the toxin that's produced by the bacteria rather than the fight against the bacteria cause the symptoms. Polio used to be a huge problem worldwide in North America. Just slightly before I was born, a wave of it went through kids 15 years older than me, until we developed the polio vaccines. So it's caused by poliovirus. Most everybody in North America is immunized against it. It's one of the regular immunizations that we give people. It is endemic in West Africa and Central Africa, kind of sub-Saharan Africa. It's highly contagious through both direct contact and oral droplets. It attacks the motor neurons in the spinal cord. So the anterior horns of the gray matter of the spinal cord get attacked by it specifically, and causes severe paralysis because of the motor neuron malfunctioning. And it's a flaccid paralysis. Things don't work. Fever, headache, vomiting, again, stiff neck, depending on, because it's in the central nervous system. There are other things that cause syndromes. So shingles is pretty bad. It's caused by herpes zoster, which is what gives you chicken pox. So you have it years after you've had the chicken pox. It usually affects one nerve, so it'll go along a dermatome or a cranial nerve. You get pain and a vesicular rash. It bubbles along that, and it's like a stripe across the dermatome. And it's really altered sensation along that dermatome as well. If you get the antiviral drug started within 48 hours, you're golden. But if you miss that 48-hour window, you can have this, what's called post-herpetic pain. My father-in-law had shingles. He had post-herpetic pain across his flank. And it lasted, I think, about 6 years until he died. We now can get vaccinated against this. So it's not a bad idea. Post-polio syndromes happens years after the original infection, and it really, the big thing is weakness and muscle atrophy. A good friend of my parents, he was a lawyer, and he was the local member of parliament when I was in high school. Super guy. He had polio, and then at about age 25 or 30, he ended up with this really terrible weakness and muscle atrophy in his right arm. And that was the only thing that was affected. So he had to have suits specially made because his right arm was so much smaller than his left arm. It was shorter, and it was flexed, and it was something that he hid all the time. Another famous person that had this was Kaiser Wilhelm. If you ever see any pictures of Kaiser Wilhelm, he always is posing with his hand on the hilt of a sword because he felt that it made it look like his arm was flexed in shorter because of the position holding the sword, but it wasn't. It was post-polio. I'm going to skip over Ray's syndrome because we don't know very much about it. It's the biggest thing is we used to have small dose aspirin called baby aspirin, which they now give for prophylactic for people with heart problems. And kids with viral infections would have a fever, and their parents would give them aspirins, and it would cause this pathological change to the brain and liver. And basically, big fatty livers would result and cause liver failure, and it caused cerebral edema. It could go from everything from some paralysis or hardly anything, just some headaches, to life-threatening problems. Guillain-Barré syndrome is an interesting syndrome, and this is an inflammatory condition of the peripheral nervous system. We don't know exactly what happens, but we end up with inflammation and a whole bunch of lymphocytes that end up attacking the myelin sheath of peripheral nerves. And eventually axon destruction can happen too. So if it's just demyelinating, we're going to have impaired nerve conduction. It sometimes is caused by polyneuropathy, so just acute idiopathic polyneuropathy means sudden onset, we don't know what causes it, many nerves not functioning. Acute infectious will happen, post-infection polyneuritis, so it's inflammation of the nerve itself. It typically starts in the periphery, and we get weakness and lack of reflex responses, some flaccid paralysis, some muscle aching that starts in the periphery. And then it moves upward. So it often starts in the feet and moves up. It may affect vision and speech. By vision, it's usually the ocular motor, so it's how you move your eyeballs. The problem becomes if the paralysis involves the respiratory muscles, the diaphragm and the other respiratory muscles, and these people suffocate. So we do supportive therapy. I don't know if you've ever heard of iron lungs, but they were developed for Guillain-Barré syndrome. Probably the most famous person to have Guillain-Barré was Jonas Salk, the guy who invented the polio vaccine. And there is the conspiracy theorists came up with the idea that, well, maybe Jonas Salk had Guillain-Barré because of the dangers of the vaccination. So this anti-vaccine shit has been going on for a long time. I've known a number of patients that have had it and are doing fine now. So we have, it can come on really quickly, need supportive care, ventilators, and then the inflammation subsides, we regrow the myelin, and it becomes a bad memory. That's the best outcome. Head injuries. The biggest problem with head injuries is hemorrhage and swelling, edema. We could have like a bruising, or we can have massive swelling that causes brain death. May or may not involve skull fractures. So probably the most important one is concussion. Now, what happens usually in a concussion is this blow to the head or a whiplash type injury that causes the brain to move within the skull, and they call it coup, counter coup, and the brain gets trauma from it because of the sudden excessive movement. That's why it happens in sports injuries a lot. Taken into the boards, hit with the baseball. Headaches and amnesia are big. It says here recovery usually is within 24 hours without permanent damage. There is a lot of study now saying that you're more susceptible, and so is that damage considered permanent? Is it that the brain becomes a little looser in its adhesions? It's still up for grabs. There's more work being done now. You'll notice this slide is 2014. There's been a lot of study recently because of concussion protocols in sports and things like that, and we're looking at some of the more permanent personality changes, irritability, because a lot of the damage, the susceptible part of the brain is the frontal lobe, and it can affect executive function, especially if executive function is just forming, which is in your late teens and early 20s. It can cause personality changes because of trauma to that frontal lobe. Contusions are really just bruisings. They can be residual damage. At what point does a concussion cause a bit of contusion? This is all gray area. But it's definitely important to assess and treat. Closed head injuries is when the skull is not fractured, but the brain tissue is injured. Blood vessels could be ruptured. Open-head injuries are fractures or penetrations into the brain. Depressed skull fractures are when a chunk of the skull gets dislodged below the level of the rest of the skull and compresses the brain tissue. Basilar fractures are at the base of the skull. So oftentimes this is like things where you hit the top of your head and the spine pushes up and fractures the occipital bone at the foramen magnum. You can end up with leakage of cerebrospinal fluid from this. So hitting your forehead against the windshield, that kind of thing. Contracoup is the area of the brain is the other side of the direct damage. So you get hit on the front right of your brain, of your head, and the brain gets thrown to the back left, and you end up with a parietal lobe contusion as it bounces off the skull. Acceleration or deceleration injury, so that's whiplash. So the initial impact is coup. The contracoup is the brain bouncing back and the rebound. Open head injuries, etc. So primary injuries are like when the brain is directly lacerated or compressed or damaged. Right? Secondary injuries are if you have a bleed, a hemorrhage, cerebral edema, big hematomas, that kind of thing, infections that get in that will damage the brain further. Here's a bunch of traumas. Hematomas, we classify them by relation to where they are in the meninges. So if it's on the outside of the dura mater, we call them extradural or epidural hematomas. If they're between the dura and the pia, so between the dura and the arachnoid, we call them subdural hematomas. If they're within the brain tissue themselves, we call them intracranial hematomas. So the biggest problem with subdural is that it can tear the arachnoid, and cerebral spinal fluid will leak into the subdural space, and it creates additional pressure. I'll just let you read that and look at the pictures. So the biggest problem with all hematomas is the space that they take up, just like we talked about in tumors. So a general increase in the intracranial pressure. So all kinds of things can happen, anything that makes you hit your head. The signs and symptoms are the focal signs and the general signs of increased intracranial pressure, seizures, cranial nerve impairment that we just said, leaking of CSF from the ears and nose, maybe fever if the hypothalamus is hurt, or if there's secondary infections. We look at them with MRIs. We treat them with prednisone to glucocorticoids to decrease any edema, antibiotics in case there's infection, surgery if we need to reduce the pressure, and oxygen. Okay. The spinal cord can be injured as well. It can be dislocation, fractures of the vertebrae that will stress, compress, tear the spinal cord. Whiplash type injuries, hyperextension, hyperflexion can hurt the spinal cord. Dislocation or slippage of the vertebrae can crush, so it can cause a stenosis. Compression, especially compression fractures, if you great force applied to the top of the skull of the feet, so diving accidents or jumping accidents. can cause damage to the spinal cord. You can look at these pictures and just imagine. But you'll see in every case the spinal cord is being compressed. So a simple fracture of the vertebrae is just a single line. Compression is crushed. Wedge is just the front part's crushed or the back part, so you end up with a wedge shape and displaces the bone. Dislocation is forced out of its normal position. So here's the thing about spinal cord injuries. Damage might be temporary, could be permanent. If the damage is just in the axonal parts of the white matter, then it could be temporary because axonal regrowth can occur. If it's more in the gray matter and it affects the bodies, then those neurons die and they can't be replaced. If there's laceration of the nerve for any reason, bone fragments, anything, it's usually permanent loss in those tracts. If there's a complete transection, then everything below there doesn't work, and it's irreversible. Partial transection, maybe you can have some recovery. Most oftentimes, spinal cord injuries are just bruising. So like if you have a snowboard injury, something like that, it's usually bruising and it's reversible. Now, the sensory side is dorsal and the ventral side of the spinal cord is motor. So when you assess spinal cord injuries, if you work in a merge or something, and the person can't feel their feet, for instance, you ask them to wiggle their toes. If they can wiggle their toes, you know it's not a complete transection. You know that it's only on the dorsal side. And it might just be bruising, right? But you got to be careful because if you have ischemia and necrosis, you can have permanent damage. You can have this big vasoconstriction. You have to know the levels that the spinal cord injury is happening. And the symptoms are often far away, so you look at the dermatome map. So if somebody has problems around their knee, you're going to look at, and their inner thigh, you're going to look at L3 as the possible culprit. If it's hip flexors and up there, you're going to look at L1, etc. If people can't feel the soles of their feet and their toes, you're probably looking at the first sacral. So spinal shock, conduction impulse ceases. It's because of inflammation. If it's spinal shock, we get reflex activity coming back. We'll just kind of leave it at that. The higher up the injury, the more of the body that's involved. So I'm not going to get too much into this. So the first stage is spinal shock. The second stage is recovery from that. So all neurological activity ceases below the level of injury. No reflexes, flaccid paralysis, sensory loss, absence of reflexes, loss of control of autonomic functions, so no sympathetics and anything like that happen beyond the site of the injury. Recovery is the return of reflex activity. We can end up with hyperreflexia. And then that's when you find out the extent of damage and see if there's going to be motor activity and things like that. So if it's high, and it'll lead to tetraplegia, quadriplegia, paralysis of all four extremities. Paraplegia is the lower part. We can have ipsilateral and contralateral loss of pain and temperature sensation, depends on where. We'll just leave it like that. I'm not going to worry about autonomic dysreflexia, but this is a huge sympathetic reflex that can't be controlled. And so what happens is some sort of stimulation, infection, things like that, cause an out of response sympathetic response. So blood pressure goes up, vasoconstriction, tachycardia. So this is that feeling when you've injured yourself, sympathetic, and you can't control it. Spinal cord injuries, especially when you're paraplegic, quadriplegic, you can have urinary tract infections because you can't control. Breathing can be affected if it's high. So pneumonia is a problem. Skin breakdown, especially bed sores and things like that. Spasm pain, depression. The sooner you can begin rehabilitation, the better. You want to immobilize the spine right away because you don't want lacerations or anything like that. Traction, glucocorticoids reduce edema, and stuff like that. So we'll call this the end of this video, and we will pick up at congenital disorders shortly.